Hi, everybody. Thank you for joining us today for the second ACR TI-RADS webinar. This is Beyond 101. We're going to be doing frequently asked questions, and a lot of those questions will be case-based. My name is Jenny Hong, and I'll be moderating and presenting. I'm a neuroradiologist at Duke University Medical Center. Our other speakers are Dr. Franklin Tesler, who is a professor of radiology at the University of Alabama, Birmingham, and Dr. Bill Middleton, who's a professor of radiology at Malignancy Institute of Radiology. All of us are actually committee members of the ACR TI-RADS steering committee, and Franklin was the chair of the committee. Now, our first webinar was on February 21st, and since then, we've been looking forward to this second one. Thank you so much to all the people that gave us positive feedbacks by email or on social media. From what we hear, we're really encouraged because it seems like we are really reaching out to you and really tailored the webinar to your needs. If you haven't listened to the first webinar, it's actually available on the ACR website, and here is the URL below. And if you think that you would like to see more webinars with ACR initiatives, please let us know and send us an email. Now, April is an extremely exciting month for us. If you're looking at our pictures here, we look pretty professional, but we're actually wearing party hats at the moment because this is actually the first year birthday of the ACR TI-RADS white paper. It was online on April the 2nd, and so we're April the 4th today. And then the other exciting thing about April is that this issue of radiology is really the TI-RADS issue. We have a paper from Franklin and Bill and Dr. Edward Grant, which is on the user's guide to ACR TI-RADS. It's everything they wanted to say that wasn't in the white paper. And a lot of it is covered in these webinars. And then we also have a scientific paper on how ACR TI-RADS makes a difference to radiologists across different practices. And we'll be speaking more about this in the next webinar. Now, onto the agenda. This is covering the questions that we received from you during the last webinar and also on email. We have identified 10 top questions that we want to cover first up in case anyone has to leave, and also to ensure and emphasize to you that they're key questions. And then after that, we've got the other questions, and then we're going to take questions from you. So a few housekeeping items. You can tweet about this webinar on AC with this hashtag, hashtag TI-RADS, and you can mention ACR, myself, or Franklin. Bill is not cool enough to be on Twitter at the moment. We will take your questions during the webinar, and so just type them in during the webinar and we'll collate them and take them all at the end. First, we want to hear about you. So we're doing a poll and the option screen is coming up. Select one of the following. Who are you? I am a radiologist, radiology trainee, physician who's not a radiologist, a sonographer, or other. And 90% of you are radiologists. Great. The next question is regarding your use of ACR TI-RADS. Does your practice currently use ACR TI-RADS? Yes, no, but will in the next 6 months, and no, not in the near future. Right, it sounds like everyone that's on this webinar will be thinking about using ACR TI-RADS, or they're using it at the moment. That's great news. So now on to the questions. And I'm taking the first question. This is a question that prior to the last webinar, I also received multiple times by email. And the question is, what is the follow-up for TI-RADS 1 and 2 nodules? These are the benign and not suspicious nodules. And what is the management of TI-RADS 3, 4, or 5 nodules that are below the size threshold for follow-up and definitely below the size threshold for management? Well, here is the TI-RADS table, and you can see for TI-RADS 2 and 1 nodules, you don't do an FNA regardless of the size. For TI-RADS 3, if it's below the threshold, you don't receive any follow-up, and same for TI-RADS 4 and 5. Now, some of you are thinking, I'm calling a nodule TI-RADS 5 and it's 4 millimeters. So I'm really not going to do any follow-up or report it or biopsy it. And that makes people nervous, and I definitely get that. So in the next couple of slides, I'm going to tell you why we set these cutoffs of not doing anything and then how to report it. Does that sound good? So the rationale for ACR TI-RADS is that we want to identify nodules that are at high risk of malignancy and biopsy less benign looking nodules. And then of the nodules that are malignant, we want to target the ones that are going to be clinically significant. So what the ACR TI-RADS level does, 1 to 5, that's only based on the nodule features of the composition, the echogenicity, the margins, the shape, and the echogenic foci. There's nothing about size when it comes to the risk level. Then the chance that a nodule will be, if it was malignant, would be clinically significant. That is where the size comes in. Size does not predict malignancy. Size predicts whether the malignancy will be clinically significant. Now, of course, there are other features that predict whether the malignancy will be significant, and these are all part of the staging system, but we're assuming that you don't have any nodal metastases or distant metastases within your nodule. So let's start off with malignancy risk, and I've got a couple of slides that will hopefully convince you to let those nodules go. This is a table from Bill's paper in AJR that was published last year, where he took more than 3,400 nodules and put it through ACR TI-RADS. And in this study, there were many nodules, and he found that if it's TI-RADS 5, then it has a 35% chance of being malignant. TI-RADS 4, it was 9%, TI-RADS 3, about 5, TI-RADS 2, 1.5, and TI-RADS 1 is 0.3%. Now, this was all based on just the features, not on size. Size does not predict the malignancy, and I'll emphasize that again. But size, what size does is it does affect survival. This is a table that shows the results of 10-year relative survival for more than 84,000 patients in the NCI database. And there are two take-home points from looking at this table. First of all, the 10-year relative survival for thyroid cancer is really excellent. Now, this was for all histology types and all stages, all grouped together. The second key point to take away is that when a thyroid malignancy is less than 3 centimeters, the 10-year relative survival is almost 100%. And this is because so many of these cancers are small papillary cancers that are in the SEER database, because that is definitely the most common cancer. Then the other paper that talks about size is a paper that we published recently in Thyroid. This took the SEER database, and this time it was for 112,000 patients. This table shows the results of the effect of size on survival in a multivariate analysis. And the take-home point from this graph is that it's not until the nodule reaches, or the malignancy reaches 2.5 centimeters that the survival ends up becoming poorer and more than the baseline. This dotted line is the baseline. The further thing I want to say is that the ultrasound size is 5 millimeters larger than the pathologic tumor size, and all the patients in the SEER database, their size is based on the pathologic tumor size. So if we're saying 2.5 centimeters on this graph, we're really talking about 3 centimeters on thyroid ultrasound. So from these last two slides, does it mean that you should be only biopsying a thyroid nodule if it's 3 centimeters? Well, no, but it does mean that you can tolerate higher size thresholds than we're accustomed to tolerating, and particularly if the risk of malignancy is lower. That's what we've tried to do with ACR TI-RADS. We've tried to increase the size thresholds. Now, those that you particularly astute, you might be saying the SEER database is based on patients that have been treated for their thyroid cancers, and that is true. But there is actually a great body of evidence showing that even if untreated, these small thyroid cancers aren't actually harmful, and most of them are indolent. The first set of literature comes from active surveillance studies, which are mostly being performed in Japan. There was a recent one that was published in Thyroid by Oda, which took two groups of patients. All of them had small papillary thyroid cancers. In one group, they underwent active surveillance, and another group, they had immediate surgery for their small papillary thyroid cancers. These patients were observed for on an average of 4 years, and over that time, the people that had active surveillance, only 2% of them had enlargement of their malignancy, and only 0.5% developed new nodal metastases. The recurrence rate was the same between the active surveillance and the immediate surgery groups. No patients in either group had distant metastases, and no one died from thyroid cancer in either group. And because of this, these active surveillance programs are now being introduced in the United States. And then the other study that shows that thyroid cancer is incredibly indolent is an autopsy study. And this one was published in 1985. It took 101 patients that died from other causes. They thinly sectioned their thyroid and found incidental thyroid cancer in 36%. And these patients did not realize they had thyroid cancer in their lifetime. So it just shows that thyroid cancer is perhaps on the spectrum of normal. It's incredibly common, and it is indolent. You die from other causes, you don't die from it in most cases when they're small. So on to how to report. Well, my recommendation would be that you certainly don't need to use the full ACR TI-RADS structured reporting template that I showed you last time if the nodule is below the threshold for biopsy or follow-up. Now, the option is if you're not doing that, you can either not report or image and tell your sonographer not to image. You can image it, but don't report it. And then the third option is to just state in a sentence the TI-RADS level, the maximum size, and state that it doesn't meet the criteria for biopsy follow-up. Now, Franklin is going to take the next set of top questions.
Thank you, Jenny, and thanks to everybody for joining us this morning, afternoon, or evening, depending on where you happen to be. Start off with this set of questions. In the mixed cystic and solid nodule, does margin apply to the entire nodule or just the solid component? And does color Doppler help? Margin applies to the solid component of a mixed cystic and solid nodule, but eccentricity is important, as this image of Albert Einstein so ably demonstrates. The key point is to pay attention to the distribution of the solid components relative to the periphery of the nodule. I'll start off with a diagram showing an even distribution of solid material around the periphery of this mixed cystic and solid nodule. Most mixed nodules of this type really don't look like this because they start out as mostly solid and then undergo degeneration. So more often they look like this diagram, where they have what I call a roughly even distribution that may be irregular, thicker in some areas, thinner in others. Contrast that to this appearance of a mixed cystic and solid nodule with an eccentric distribution of the solid component. We would call this in other organs a mural nodule, and you see that the mural nodule here diagrammatically is irregular. But the key point is that it's eccentric compared to the periphery. Here's an example. This is from the How To article that Jenny mentioned earlier from the current issue of Radiology. It's a mixed cystic and solid nodule with solid components around its periphery, relatively smooth and even in appearance. Contrast that to this cancer, which shows a mixed nodule with this lobulated solid component that you see multiple irregularities or lobulations along its margin, protruding into the nodule eccentrically. This also has multiple punctate echogenic foci within it. The same is true of this example from the literature. There have been several papers over the past few years dealing with this type of nodule, and all of them talk about the eccentric appearance, the lobulation of the solid component, and they also point out to punctate echogenic foci that we see here as an important sign. What about color Doppler? Color Doppler can be helpful to distinguish tissue from schmutz. And for those of you not familiar with that word, it's a Yiddish term that means dirt. And I'm referring to here to non-specific, non-tissue material within thyroid nodules. If you see flow, that means you're dealing with living tissue, as in this nodule on the left. Lack of flow, however, doesn't always mean that you're dealing with necrotic tissue or debris. On the other hand, layering, as illustrated on this nodule on the right, the arrows are pointing to layering material. That refers to debris that you don't have to be concerned about. Next question, should a nodule suspicion level be reported? This is a very frequent question that I've received from people in multiple places, so I'll deal with my perspective on it. Here's the relevant part of the ACR TI-RADS chart. My answer to this is it's really up to you, but I usually don't report suspicion levels. Here you see that going from TR1, TR2, 3, 4, and 5, you have different points associated with each one, but you also have the descriptors that the ACR TI-RADS committee applied to each one, going from benign, not suspicious, all the way up to highly suspicious. I think that those terms were appropriate relative to one another. However, the reason that I usually don't report suspicion level is that referring physicians and especially patients may wonder about highly suspicious nodules that are not being biopsied or in some cases not being followed, as Jenny referred to earlier. One option would be to refer to numeric risk ranges. This is a part of the same figure that Jenny showed earlier from Bill Middleton's article in AJR, showing that as you go up in points, what the risks of malignancy are. And you can certainly choose to report these, but I think that could be misleading as well. That's because the risk or probability of malignancy is not the same as the risk or probability of harm to the patient. As Jenny mentioned earlier, thyroid cancer is different. So a risky nodule or a risky lesion in some other organ, say the lung or breast, is different as far as harm to the patient goes compared to a nodule in the thyroid gland. Next question. Because punctate echogenic foci, or PEFs, are awarded 3 points, what can be done to avoid overcalling them? And how should linear echogenic foci be reported? It used to be thought that these echogenic foci mostly represented so-called Samoma bodies, also known as calcospheroids, which are really small, 0.07 millimeters. I don't know that our ultrasound machines can really see them down to that level, but they often occur either in clumps, and we may be seeing clumps of them in many cases. Here's an individual calcospheroid or Samoma body, and you see the typical lamellated appearance with this concentric configuration that they show under the microscope. Mike Bieland and co-workers published a very interesting article on punctate echogenic foci several years ago in the Journal of Ultrasound and Medicine, and they classified them into 4 categories shown here. The 2 at the top, including larger ones with comet-tail artifacts, which we recognize as colloid, and the linear ones that you see in the top right, were benign. The small and even smaller punctate echogenic foci, which tend to be 1 millimeter or less and non-shadowing, tended to be malignant. And these 2 on the bottom are the types that we're looking for. However, the association between them and psammoma bodies is not as strong as we used to think. In this article from the group at Stanford in 2016, it was shown that only 45 to 48% there was a positive predictive value of that low for psammoma bodies. That is, most of these punctate echogenic foci, the small ones, were not psammomatous calcifications. And here's an example from that article showing a papillary thyroid cancer with multiple small echogenic foci that I'm pointing out here that we would certainly call PEFs, but none of those turned out to be psammoma bodies. In fact, some of them, or many of them, were coarse calcifications. Here's some examples from my experience. This is a proven papillary thyroid cancer, and you see throughout it multiple echogenic foci of varying size. Some of them look like they have comet-tail artifacts, but it's possible that many of these are not psammoma bodies, although on pathology, this did have some psammomatous calcification. Here's another example. This is from an 11-year-old patient, and you can see scattered small punctate echogenic foci throughout this nodule. Again, many of these may not be true psammomatous calcifications. And finally, this is a nodal metastasis from a patient with papillary thyroid cancer, showing a few scattered punctate echogenic foci coming into and out of the field of view. Those are the abnormalities that we're looking for. However, it's important to distinguish true punctate echogenic foci from speckle, which is the pattern that we see in parenchymal organs like the thyroid that mostly results from interference, and non-specific, what I call dots and dashes. These are 2 normal or near normal thyroid glands, and you can see that I'm pointing to small dots and sometimes linear echogenic foci throughout. These are normal and should not be mischaracterized as punctate echogenic foci. So before calling them in a given nodule, I look at the adjacent parenchyma or the parenchyma elsewhere in the gland, and I make sure that they're really confined to the nodule and they're well-defined and rounded. Next question, if there are more than 4 nodules, should the sonographers take images of all of them? If not, how do they know which ones to image? Are there exceptions? I have 2 sets of guidelines on this for you. One, if there are no prior studies. I always start with overview images, and clips are better if you can do them to show the entire gland, sagittally and axially. The sonographer should take images of and measure and annotate the nodules that are most likely to need FNA or follow-up. In order to do that, they need to know ACR TI-RADS, which is why we have the ACR TI-RADS chart in all our scanning rooms. And we formally report or score up to 4. Very, very rarely do I ever report more than 4. In fact, I don't remember ever having to do that since adopting ACR TI-RADS. This clip shows the value of an overview scan. It gives you an idea before you start measuring or annotating anything which nodules to focus on. My guidelines for prior studies are slightly different. It's important to review priors, whether it's ultrasound, CT, MR, PET, or radionuclide studies, to see which nodules to assess. The exception is pre-ACR TI-RADS ultrasound. In other words, if you used to be in a practice, or you are in a practice that used to measure every nodule, there's no need to continue doing that in the ACR TI-RADS level. Again, begin with overview scans and measure and annotate and image the nodules that were noted on priors are most likely to need FNA or follow-up. So, for example, if you have a PET scan that shows something that's FDG positive, you definitely need to report that on your ultrasound if there's a corresponding nodule. If there's a CT that shows a nodule, you need to report that on your current ultrasound scan, even though it may not warrant FNA or follow-up. And that's to answer the clinical question that for which the ultrasound was ordered. And again, I very, very rarely, or in my case so far, never report more than 4 nodules in a gland. Should ACR TI-RADS be used in pediatric patients? The answer is technically no, but a nodule that's suspicious in adult is even more suspicious in a child. I refer you to this article in Radiographics from last year, and you'll notice in the first bullet point that they say that individual thyroid nodules in a pediatric patient has a 3 to 5 times greater risk of malignancy than in adult. And now I'll pass on control to Dr. Middleton.
Thanks, Franklin, and thanks to everybody that's joining us today. We have a few more questions to get through. The first one that I was assigned to tackle was, how do we distinguish spongiform nodules from mixed cystic and solid nodules, or solid nodules with minimal cystic components? Well, first of all, we need to go back to the definition of a spongiform nodule. So they are defined as a nodule that's composed predominantly, meaning greater than 50%, of tiny cystic spaces. So they should all be predominantly cystic in composition. Now, it's okay to have larger cystic spaces within a spongiform nodule. That doesn't negate the fact that it's cystic or that it's spongiform. So if you look at this nodule here in the lower left-hand corner, this is a classic spongiform nodule. It's predominantly cystic, multiple tiny little spaces, and a lot of septations kind of separating those cystic components, but very minimal solid component here. If there are larger solid components, then you have to put it into the mixed cystic or solid category. So these are two mixed solid and cystic nodules. Note that this nodule is relatively similar to the spongiform nodule. It has a lot of small cystic spaces in it, but there's just a considerably larger amount of solid material. So this would be better classified as mixed solid and cystic. Same thing for this nodule on the right. There's a lot of cystic spaces and multiple scattered little cystic components, but there's just too much solid material here to call it spongiform. Mixed solid and cystic nodules, in distinction from spongiform nodules, tend to appear in sort of 4 discrete categories. So many of them, I would say most of them, are solid with scattered cystic spaces, and that's what we're seeing here. They can also be cystic with thick or irregular septations. That's what we're seeing here. They can be cystic with thick walls. Franklin showed an example of that earlier. Or they can be cystic with mural nodules, and Franklin showed examples of those earlier, similar to this one. That's what you typically see with mixed cystic and solid nodules. Now, the question was, how do you tell the difference? And sometimes the reason that you're having a hard time telling the difference is that you're having a hard time getting a good look at the nodule. And for the sonographers that are in the audience, you all know that there's a trade-off between penetration and resolution. And in each nodule that you evaluate, you want to make sure that you use the transducer that will give you the needed penetration as well as the highest possible resolution. So that will depend on the depth of the nodule and the thickness and composition of the soft tissues in the neck. And then it's also important to take cine clips on nodules where the composition is difficult to determine from static images. This is an example where we can see this nodule. There certainly are spongiform components to it here around this periphery, but there's a substantial solid component as well. And you might have trouble deciding where to place a nodule like this. When you look at the cine clip, I think it's pretty clear that the solid components are relatively minor compared to the cystic components. And this is one that I would have called a spongiform nodule. Next question, what are the exceptions to ACR TI-RADS? Well, there are a number of exceptions. Some that sort of apply to a broad category of patients are listed down below here. So patients with clinical risk factors, such as MEN type 2, radiation in childhood, family history, those sorts of things. Sometimes you need to make an exception because of referrer or patient preference. And sometimes advanced age or significant comorbidities will change how you approach a nodule. But these are the cases in this box that I want to highlight individually. So the first is FDG positive nodules. This is an example of a 63-year-old man with an invasive pituitary microadenoma. Had a PET scan that showed an FDG avid thyroid nodule in the right lobe of the thyroid. So he came to ultrasound, and you can see that he has scattered similar appearing nodules, the largest of which was about 8.5 millimeters. It's solid and hypoechoic, 4 points, so it's a TR4 nodule, and under normal circumstances, a nodule with this size and this TI-RADS level would be followed at 1, 2, 3, and 5 years. But because of the positive PET scan, this is a nodule that really should be aspirated for a couple of reasons. One is most of the time the management will change depending on whether it's a thyroid cancer or metastatic disease to the thyroid. And there is data that shows that cancers that are FDG positive have a worse prognosis. This is another example of a patient that just came in with a history of a thyroid nodule. We didn't really know much else about this patient at the time. And you can see when you look at the static image and the cine clip, it's solid, it's hypoechoic, it's got a macrocalcification and a PEF. So this is a TR5 nodule, but it's less than a centimeter. So it doesn't meet criteria for FNA, it meets criteria for yearly follow-up. However, in this patient, there's also a suspicious lymph node. This is a right level 3 lymph node that has cystic areas and a few little bright foci, very suspicious for metastatic disease. And in a case like this, the nodule and in many instances, the lymph node should also be aspirated. This is a 41-year-old woman who had a left thyroid nodule seen on a CT scan. Referred to ultrasound, you can see the images here on the left. It was a 1.2 centimeter nodule, it was solid, very hypoechoic, that's 5 points, so it's a TR4. That would meet criteria for follow-up, but not for FNA. However, look at the location of this nodule. It's posterior in the thyroid, and it's immediately adjacent to the esophagus. If you look at this diagram, you can see where the recurrent laryngeal nerves are. They're right next to the esophagus in the sort of groove between the trachea and the esophagus and the thyroid in the esophagus. So nodules that are in this location are at increased risk of involving the recurrent laryngeal nerve. If the nodule enlarges just a small amount, that's going to put this patient at increased risk of surgical complications and increased risk of postoperative morbidity. So in this particular location, it's important to be more aggressive. And in this case, an FNA is probably necessary to confirm, first of all, that it is a malignancy, and then perhaps to be more aggressive in approaching your follow-up or referring to surgery. This is a 58-year-old woman with hyperparathyroidism. When doing the scan to look for a parathyroid adenoma, we found this small nodule, measured a maximum of 7 millimeters. It's solid, hypoechoic, and has PEFs, so that's a TR5 nodule. But because it's less than a centimeter, it doesn't meet guidelines for FNA, meets guidelines for yearly follow-up. However, this patient has hyperparathyroidism. Here's the parathyroid adenoma. This patient's going to the operating room anyway to deal with the parathyroid adenoma, and there's no reason to ignore the thyroid cancer when you're already in the operating room dealing with thyroid and parathyroid tissues. So this is one that really needs to be FNA'd, and if it does in fact turn out to be cancer, then the surgeon would do the appropriate surgery at the time of the parathyroidectomy. This is a 58-year-old woman with neck pain, so symptomatic nodule rather than an asymptomatic nodule. If you look at these scans, they're scattered, poorly defined hypoechoic regions within the thyroid, the largest of which measured 19 millimeters. They were solid, very hypoechoic, TR4 nodules. Normally, this would meet criteria for FNA, 1.9 centimeters and a TR4 nodule. But this patient has neck pain that was very suggestive of subacute thyroiditis. And the ultrasound images are also very suggestive of subacute thyroiditis. So in a case like this, it's appropriate not to do the FNA, but to do follow-up scans instead. And these follow-up scans showed that things did resolve on their own. Here's a 50-year-old woman with a prior history of FNA of a right-sided nodule that was benign. Now she comes in with this nodule seen. It's solid, very hypoechoic, has PEFs, 8 points. It's a TR5 nodule, and it measured a maximum of 1 centimeters. So normally this would meet our criteria for FNA, just barely, but it would meet that criteria. But when you look back through the old records and the old images, you see that this is what this nodule looked like when it was initially seen and initially aspirated. This is a complex cyst that's just involuted over time and has become a suspicious-looking solid nodule. This is a phenomenon that's called mummification of cysts or involution of cysts, and it's a thing that you should be familiar with, because in a case like this, you certainly would not want to repeat the FNA. Next question. How should we determine echogenicity, especially distinguishing iso from hypoechoic nodules? Well, let's go back to our ways of defining and classifying echogenicity. First of all, remember that you compare it to the thyroid and to the strap muscles, and you only evaluate the solid, non-calcified portions of the nodule. So here are two different nodules. They're both hypoechoic to the thyroid. This one on the left is also hypoechoic to or greater in echogenicity than the muscle. This one on the right is equal to the muscle. Both of these would satisfy our criteria for a hypoechoic nodule. They don't get defined as very hypoechoic until they're less echogenic than the muscle. So these would both be hypoechoic and awarded 2 points. Then the next question is, how do you optimize the image to distinguish the echogenicity of a nodule? And again, you need to use the appropriate transducer and obtain cine clips when necessary. Here's an example of a patient where we have a nodule and there's peripheral calcification that is causing a fair amount of shadowing. In this case, you probably would have to say you can't tell what the echogenicity is and assign 1 point. But when you switch your probes from a higher frequency probe operating at 15 megahertz to a lower frequency probe operating at 8.4 megahertz, you can see that the penetration is improved. You can see the internal characteristics of that nodule. It's hypoechoic, so it gets 2 points instead of 1. And in fact, you see a few little PEFs here as well. So it would get an additional 3 points. So optimization of the image is very important, especially to the sonographers out there. Now, specifically in distinguishing isoechoic from hypoechoic, there are some tricks that you can use. This is the image that was originally taken of this nodule, and it looks like it probably is a little hypoechoic to the surrounding parenchyma. But it's a close call. If you increase the gain, sometimes that helps. And I think it's a little bit more obvious here that this is a hypoechoic nodule. You can also adjust the dynamic range, and generally you want the dynamic range to go down, which will give you more image contrast. And in this case, that made it, obvious that this was a hypoechoic nodule and not an isoechoic nodule. It's also important to distinguish hypoechoic nodules, which get 2 points, from very hypoechoic nodules, which get 3 points. And those same techniques can help in this situation. This was the original image. You can see that this is pretty close to the same echogenicity as the strat muscle. Hard to know if this is hypo or very hypo, but when we increase the gain, everything gets brighter, but the strat muscle gets brighter to a greater extent, and this is, in this case, a very hypoechoic nodule. Next question. If a nodule is truly round, in other words, not wider than tall and not taller than wide, how should it be scored? And the simple answer is it should be reported as not taller than wide, and it should be assigned 4 points. So a nodule like this, where the AP and transverse diameter are identical, this would be reported as not taller than wide. But that brings up the question, what do you do with spherical nodules? And do they really not have an increased risk of malignancy compared to ovoid nodules? And there hasn't been a whole lot of study that has looked specifically at that. When I got this question, I looked back at the SRU database and specifically looked at nodules that were spherical. And I defined those as the maximum diameter was within 1 millimeter of the minimum diameter. And if we just looked at nodules greater than a centimeter, then of all spherical nodules, 18% were malignant. Of nodules that weren't spherical, the malignancy rate was much lower. Malignant nodules were spherical in 4.5% of cases, and benign nodules were spherical in 1.9% of cases. Now, this is a very selected group of patients, and there's a lot of biases in this analysis. But it is possible that in the future, we may end up giving more than 0 points for nodules that are spherical. So that takes care of all of our 10 most common frequently asked questions. We do have time left to cover some other frequently asked questions. And this was the first one that I was assigned. Is there a size below which a nodule cannot be accurately characterized? And the answer to that is yes, but it depends on a couple of things. First of all, it depends on the nodule's composition. So pure cysts can be, accurately characterized as cystic when they're very small, down to 2 to 3 millimeters. But mixed solid and cystic nodules and purely solid nodules are a little bit harder to characterize when they're less than 5 millimeters. It also depends on the thickness and the composition of the tissues in the neck. So patients with short, thick, fatty necks, generally it's hard to characterize lesions that are less than 5 millimeters, and sometimes hard to characterize lesions even larger than that. But in your skinny patients with long necks and little fat, even solid nodules can be characterized when they're 2 to 3 millimeters. Fortunately, we almost never recommend follow-up or FNA for nodules that are less than 5 millimeters. And then the next question, what should be done if a nodule changes and receives a follow-up score that's higher than the scores of previously followed nodules? So this is assuming that you've got a previous exam that's been scored by TI-RADS. And my answer to that is, if you're previously following 3 or fewer nodules and you have a new nodule that's got a higher score than those 3, then you just add it to your recommendations. But if you've previously been following 4 nodules, then you have to replace the nodule with the lowest score with the new nodule with the higher score. You continue to just follow the 4 nodules with the highest score. And then finally, how should we handle patients who had an ultrasound that was done prior to ACR TI-RADS and may have had more than 4 nodules followed? Well, first of all, I feel sorry for you that you're following more than 4 nodules, and that's one of the reasons why the TI-RADS system, put a limit of 4. But basically, you just start over again, and you determine which of the nodules have the 4 highest scores, and you follow the recommendations for those nodules. In many cases, you'll end up following less than 4 nodules. And if you're lucky, and if the patient and the referring physician are lucky, you won't have to follow any of those nodules that were previously followed prior to TI-RADS. Okay, so that does it for all of my frequently and less frequently asked questions. I'm going to turn the controls back over to Franklin, and he's going to include a few more of the asked questions.
Thank you, Bill. And let's see if I can, there we go. There we go. In determining management, should the nodule's largest measurement or an average of all three measurements be used? That's an easy one. It's the largest measurement that determines management. What should we report for previously biopsied nodules? This is a fairly frequent question. And we said in the white paper that management is usually going to be based on the referring practitioner's request. This, which is going to be based on what the previous biopsy showed. There's a chart actually that's missing from this slide from the latest ATA guidelines, but basically it showed the 6 categories in the Bethesda classification. And often you won't know what the last biopsy was. You may know that it was benign. You may not know if it was an intermediate category. So generally, request for further management of those will be based on information that the referring practitioner has. What if there are 2 nodules with the same TR level? One meets the size criteria for FRNA, but the other doesn't. What recommendations should be provided? Here, we follow the chart recommendations for any TR level. So for example, if you have a TR3 level, one of which is 3 centimeters and the other is 1 centimeter, the larger nodule will warrant FNA and the smaller nodule will not even require follow-up. So it's just basically a matter of following the chart. That's it for my additional questions. And I'll pass control on now.
Well, it's me again, Jenny. Thank you, Bill and Franklin, for such fantastic presentations. I enjoyed learning more Yiddish. And Bill, that case of mummification was fantastic. I think I have control now. My less commonly asked questions are, is ACR TI-RADS an accepted standard? And the answer is no. It's a white paper. It's guidance. It doesn't even meet the criteria of guidelines as required by the National Guidelines Clearinghouse. But it was developed under the auspices of ACR, and it is evidence-based to the greatest extent that we have it. Franklin did a fantastic job of leading the committee, as I've mentioned before. And compared to many other committees I've been on, we had multiple conference calls, as I mentioned, very long emails from Franklin and other members. And Franklin even implemented multiple surveys so that our final product was really based on consensus. And then Bill applied the SRU database to what we came up with ACR TI-RADS. So it's not an accepted standard, but it's a very, very good one. The other question, which I've heard before for other topics, is should reports include a disclaimer stating that some cancers may be missed? And I'd say no to that. But definitely you should be try to be definitive as much as possible with your reports. And I lecture about this at another situation. Then why not give an overall ACR TI-RADS score to the thyroid rather than individual nodules? And I think this comes from people that are very familiar with a BI-RADS and like one overall score. Well, for ACR TI-RADS, it doesn't quite work that way because we're not evaluating the thyroid gland as a whole on one image or 2 images, as with mammography. We're evaluating a thyroid which often has more than one thyroid nodule. So to give an overall score based on an average of the nodules or the most suspicious nodule really doesn't explain the whole picture, and it is best applied to individual nodules within the gland, and as we've said again, up to 4 nodules only. The other question was, can ACR TI-RADS a structured report be, where can it be found? It can be found on this website here. You can also just Google ACR TI-RADS and this will probably be the first thing that comes up. And on this website, we have a short introduction to what the goals of ACR TI-RADS are. Here you can see the last webinar is already there as a video. This takes you to a YouTube link. We've got how to sign up for the next webinar here. The last one will be on the evidence behind ACR TI-RADS. And then we've got links to all the articles that members of our committee have published on ACR TI-RADS. And then at the bottom, we have some tools on the template, a small atlas, and then a sonographer's worksheet. So just Google ACR TI-RADS and you'll get to that. And here are some examples of the resources. So we have a couple minutes left, and I want to draw your attention to the next webinar, which will be on May the 30th. Which will be the final one, and it's evidence behind the performance. As I mentioned, we are celebrating the 1-year anniversary of ACR TI-RADS. So we have since then published several papers on the evidence behind ACR TI-RADS, and there are other people outside the committee that have done that too. So we hope to put it all together and show you how ACR TI-RADS does as a whole, how it does to radiologists' previous practice, and how it does compare to other guidelines out there, such as the ATA and the Korean and French TI-RADS. And the most common question we got from the last webinar was this one: will this recording be available after the webinar? And the answer is yes, this one and the prior one and the next one. For more questions, email rads@acr.org. In particular, I would be really interested to hear from you your initial experience for the people that have started using ACR TI-RADS. Is it taking longer? How long did it take before your radiologist got familiar with it? Do you like it? And I, as a PI of the registry study, I've definitely heard mixed responses. But overall, what I've heard is that for each individual nodule, it does take longer to apply 5 categories to the nodule, but because I'm not reporting as many nodules, it probably takes about the same amount of time, but I know I'm doing a better job and patients are getting more standardized reports and recommendations. So we have a couple minutes and we're on to your questions. So far, I haven't received any questions, and I also like to take this opportunity to thank Lauren Hicks, who has been working behind the scenes to deal with our multiple versions of presentations and getting us organized and helping with the publicity of these webinars. Thank you so much, Lauren, for your work. So there are no questions. Franklin and Bill, do you have any comments that you've heard about people adopting ACR TI-RADS, whether they've struggled, whether people have been on board, whether they've adopted and then reversed back?
I'll take this. This is Franklin. I haven't heard anybody who's done any backsliding. I have heard from several people that it was harder than they thought it was going to be. Mm-hmm. So I think you have to devote the time and be patient. In practices where the sonographers do the majority of the imaging and then radiologists do the interpretation, you have to take the time to allow the sonographers to learn the system and know what images that they need to take. So for example, if they scan a gland and take images of and annotate 10 nodules like they may have been used to, that makes it harder for the interpreting radiologist, who then has to pick which 4 nodules or fewer perhaps to actually report. It takes, you have to give it time for that to happen. But once you get going, I think I agree with what you just said. I find I'm working more quickly than I used to, and I'm certainly more consistent. And the radiologists across our practice here are more consistent with each other than they used to be.
Okay, yeah, great. Yes, certainly the educational component is really key, and I would recommend to the listeners that you forward the links to the webinars for your sonographers and your radiologists. It is a really very concise way to get up to speed with ACR TI-RADS. Bill, I have a question for you that's come from the audience. What does one do with a known malignant nodule, i.e. BI-RADS 6? How would you report it?
Now, I'm sorry, say that again, Jenny?
How would you
TI-RADS 6?
Well, how would you report a nodule, a thyroid nodule that is known to be malignant?
That you're actively surveilling?
Yeah.
So the most important thing there is to document size changes and to document the presence or absence of any suspicious, cervical lymph nodes.
Right.
In both of those cases, then the patient would probably end up going to surgery.
Yeah. So this is a case that's really similar to the active surveillance programs in Japan. If there's a change in size or if there are new nodal metastases, then that would be a point where you draw the attention to it and say that it's progressed, and those patients would more likely get surgery. And also any invasion outside the capsule, if that's been a change as well, that's really important. The other question I'm going to pass on to Franklin. Is there a specific definition for a multinodular goiter in TI-RADS? Do you assign a TI-RADS category to these nodules?
There is no specific definition for a multinodular goiter, although I hear that term misused fairly frequently. Goiter simply refers to an enlarged thyroid gland. I use the term multinodular goiter when the gland is overall enlarged and there are multiple nodules that are causing that enlargement. That is, if you have an enlarged gland that is basically normal in echotexture and has multiple nodules that are small, I wouldn't call that a multinodular goiter. What I do in those cases is I look for any nodule that stands out by virtue of its ACR TI-RADS classification. If there are multiple nodules that are similar and relatively low in suspicion, say TR3, and they're scattered throughout the gland, I typically just recommend follow-up for those. I don't think there is any value for just biopsying the largest nodule simply because it's larger than others. The problem in glands like that is that there is a lot of room for sampling variation if you, how do you pick which one to biopsy? And again, the way to do that is how it compares to the other nodules in the gland. But I understand those are difficult to deal with. In fact, those glands make it really hard to measure nodules because they're often confluent and it's difficult to see their borders.
Right, great. Well, we don't have any other questions, but I will say that, Franklin, I really enjoyed that slide where you said we're looking at the probability of malignancy and then also the probability of harm. And that is a particularly good point to emphasize when we're not doing follow-up or biopsy for small nodules and we're choosing not to use these terms of highly suspicious, moderately suspicious, so that we're not alarming patients. And I think that that's the end of the webinar. If no one else has any questions, I'm going to take you back to the original slide, which gives you the link to the resources, the ACR webpage, and it's constantly being updated. I think what we'll do is we'll see if we can list all these questions out and maybe give you a time in which it is present on the video so that you can go back and refer to specific questions or refer other people to these specific questions. Franklin, Bill, do you have any other comments in our last minute?
One last comment. We know that ACR TI-RADS is far from perfect. So if anybody out there has any specific recommendations for improvement, please pass them on to me or anybody else on the committee, and we'll take those into account as we consider revisions in the future.
Okay, great. Bill?
Nope.
Nope. Okay, thank you.
No additional comments.
Thank you, everybody. Thank you for tuning in, and we hope to see you on May the 30th at 1 p.m. Eastern Time for the final chapter of the ACR TI-RADS webinar. And please send in your comments. We love getting fan mail, and we also like to hear constructive feedback as well. So thanks for reaching out to us, and like us and subscribe to us on YouTube. I've always wanted to say that. Thank you.
Bye, everybody.
Bye, everybody.
Bye.